Notice here the new bone on both sides of this suture. When we treat with a headgear, we can open up space anteriorly by moving the molars back, but also this is a shielding device. So we have a lateral bumper here. Instead of pushing the teeth out, we're doing a little Frankel effect here, of pulling on the cheeks, holding the cheeks away during the swallow. Now, when it's working right, you should be able to look in the mouth and see a visible mid-palatal suture. These are some of the changes that we've seen in joints with degenerative joint disease. Notice the condyle's flat. Notice the eminence is flat. There's a tooth missing. The mandible is class 2. And the teeth are worn. Look at the wear of the teeth here and look at the condition of the condyle. This is rheumatoid arthritis. Here's the ear hole.
What is that again?
This is the ear hole or the chorion. And the condyle was destroyed by rheumatoid disease. Now here's the old eminentia. And fossa. This is all filled in now. And you got a false joint out here on top of the eminence. So that's rheumatoid arthritis at a young age. Here's a patient that was in 1963. They had scoliosis. Scoliosis of the back. They put a Milwaukee brace on. And you can see how this was pushed up. Here it was, and here it was in 2 years. But look what happened in the upper face. Here the upper face was moved upward and forward from here to here. The key ridge. The orbit. The nasal bone. So the whole complex was twisted upward and forward. You're all familiar with the Colombian Indians that put plates on the children's head to flatten them here and flatten them here so that they could mold the growth of the head. I showed you this before. And this was the girl that fractured the transatlantal ligament. She was in the hospital and fell out of bed on the back of her head and fractured this ligament. And here was this girl from 4 to 6. No treatment. What happened is she went ahead and developed the upper arch normally. And she went from an end-on to a class 2 malocclusion in the deciduous dentition. She was also a bruxator. A lot of children are clinchers. They're milling in the teeth. We don't know all the causes of bruxism. But we do know it's very common in children. Now, she was one of them. So she had inhibited the growth of her condyle, and you notice here in this 2-year interim, it had grown flat like this. Okay, now, I'm a great believer in using extraoral traction for crowded upper dentures and for class 2s. You're seeing here this pterygomaxillary fissure is now bending backward. If you look closely, this suture is opening up right here, and so is the nasal suture. So we believe in maxillary orthopedics. This is a patient that was treated back in 1953. It was a Brody syndrome. This isn't the same patient here. But this is from a publication in 1958. If you look here now, before and after treatment, superimposed on salinazion, you notice that the pterygoid palatine area has been modified. The orbit has been dropped down. The key ridge is moved. The whole palate is moved. And the upper molar has been moved back from 17 back to 9 millimeters. Now that's beyond anything that anyone has ever seen in the absence of treatment. So this is an environmental effect. The headgear was the environment. I showed you this case yesterday. The one that we had expansion in the upper arch. From here to here. And how we gained this width and width through the nasal cavity as well. I have this patient that I want to show you. It was a patient that I diagnosed and prognosed to have vertical growth. You can see there's something in the environment here. Either a thumb or a tongue or both. This is still a deciduous tooth, and you can see he has no room for the lower lateral on the other side. Now we put a high pull headgear on him, and we took out his deciduous canines and made a serial extraction case and moved him back into a class 1. Here he was at age 7. So here we are now at moving this upper molar back to get a class 1. And we achieved it because here we are now
急になりました。
showing that we got orthopedics in here. But what do you also see now? Look very closely at this illustration. Contrast that to what I've shown you before. That's almost a year and a half difference between the two. What do you see? Anybody? What did we do when we took these teeth up? We had a high pull headgear on them. We took the posterior teeth out of occlusion and we got a direct jamming of the joint. So the condyle was compacted. Here is position 1. And he did go from 80 to 82 on the facial axis. And this is now from 7 to 8.5. So that's a year and a half. That's about 3 to 5 months of growth.
ここでは3ヶ月から5ヶ月ぐらい分のその成長しかありません。
Now, he goes off and is transferred to Frankfurt, Germany. His father went over there to work. He came back and we finished it. And here he is 4 years later. He's gone back to 78. He was 80 to start with. Now he's all the way back to 78. Certainly we got more orthopedics on him. Look, so that's a lot of hard work. Now, here he was at age 7. And here he is to age 12. He's had a lot of backward movement of point A. Look at it. But in all that time, in 5 years, he's only had this much growth in his mandible. And so that's not very much. So we retained him. Now by age 16, he came back and he was class 2.
2級になっていました。
He's down to 74. In a Caucasian sample, that's 16 degrees on the south side. What was wrong? This bothered me a great deal. So one day I got this boy's records on it. There's got to be more to this than just a vertical growth pattern because I treated his brother. And what do you see now at 16? Notice he's also going back into a crossbite again. Notice that one side of his nose is completely blocked.
この子はオープンバイトがありました。
Had fallen down and knocked one of his centrals out. He looks like he has a normal airway. This is today what a lot of people would call the long face syndrome. It would be a candidate for a Lafort impaction with a mandibular rotation and a genioplasty today. He's only 9, so we decided to treat him, take out 3 of the teeth, close his face up and put a jacket on for the central. So with a lot of hard work, by almost 12 years of age, we're able to get him down to an end on. And I thought that was about the best that I could do because that was a lot of work to get it done. So here from the age of 9 to 11, see, we were able to not to open his mandible too much. He didn't have extraoral traction, so this was just tooth movement. And he comes back now at 19. He's worse off than when I started. He's got 125% relapse. Here he was to start with. He's still continued to grow south. His oral gnomon is 67 degrees. Now, what caused this? Now, and I remember him having always a whine in his talk. Denasality in his talk. He always sounded like he had a cold. But I kept looking at his nasopharynx. It seemed okay. I just assumed that this was his natural growth pattern. So a few years later, I went back and got the records out and started looking at them. And to my embarrassment, he had a chronic sinusitis from the very beginning. He had a complete deviated septum. I could only partially breathe through 1/2 of his nose. I use these cases then to show that function works for you or against you. I consider the thing that was the greatest breakthrough for clinical research in orthodontics to be the computer. When we started making composites, I could visualize changes rather than trying to sit there and imagine what a meaning of a number meant. Broadbent used 16 patients. Brody used 16 patients. And what they did was to take 2 and 2 and 2 and 2 and reduce it to 8, then reducing that to 4, then to 2, and then to 1. Now with the computer, with a relatively simple program, we can put all the data in and simply ask the computer to print out the mean of all of that sample. So we come up with an imaginary picture of that sample of patients. Now with this, we can take 2 samples and compare them to each other, and immediately we can see then whether or not we're dealing with the same kind of a situation. Let's suppose, am I going to show you here now, that we take a group of patients and treat them with one modality, and then take another group and treat it with another modality. What we have to do also is match them up for males and females now, which I didn't do in the beginning. But now we've found that there's a difference in males and females significantly. So I've got to go a whole nother round of research now in order to be exact. So we're going to compare the same patient to himself at a later time, or the same group to another group at a later time. When I first started working with composites, we didn't have a program. And so the means of the samples was something that I worked up manually. So just based on the data and corrected for the occlusions, using normal occlusion samples to match it up. This is how we arrived at the pattern for an 8-year-old child in the mixed dentition with a normal occlusion. The same procedure then was done for the age 11 and the age 13. So based on these, we could take the 8-year-old and we could then go with the 13-year-old, and we had a picture then of normal development. Now in this 5-year period from 8 to 13, they grew about 12.5 millimeters here, and you can see the Bayesian A didn't change. We could then see how the nose grew. Then we moved back up to the position 3, and we could see how the nose was growing, how much thickening of the upper lip took place. And then down on position 4, we could see the teeth and the soft tissue here. Instead of a manual workup, this is really the computer. I think this is 20 patients. Instead of from the ages 8 to 13, it was from 7 to 12. You notice we found the same thing. This sort of enhanced and gave us confidence in what we were seeing before, and it gave us confidence then in normal development. So this gives us an idea then as to what normal expectancy would be, and based on all our work then we made a composite for 3, 4, 5, 6, 7, 8, all the way through for boys and girls. So for the Caucasian, we have in the computer then enough data that, and it's been reconfirmed that we have a high degree of confidence in the reliability of it. So several years ago I asked one of the girls in the office to find me a group of patients who had been extracted. Now we can do several things with this sample. One of the things is that we can compare it to an 11-year-old sample and see what the difference is in a group of cases that were extracted are with the so-called normal. All right, now what were the characteristics that led Ricketts to extract teeth? Here's the normal at 11, and here are the extracted cases at age 11. So we can visualize the differences very rapidly. What's the first thing that strikes you? The chin. So in the extraction cases, we're dealing with a deficient mandible. But if we superimpose here on CC, you can see that the chin is short and back. You see there's a failure of descent of the palate here, so the palate's up a little bit. Superposition of position 4, you can see that the lower incisor is back. And we superimpose on position 4, you can see that the mandible is flatter, and there's really a significant difference in the length of the condyle. So one of the factors that influenced us undoubtedly then was the mandible. And it's a mandibular problem that led us then to extraction. It was almost 91. So it was not really back, it was just small. Okay, now here they are then after treatment in 4 years. We took the last x-ray at the time when they were safely in retention. At that time, when we could quit seeing a patient regularly in retention, we transferred the records into a permanent file. Some bending of the nasal bone downward and some crossing over of the nose. And what does that indicate to us? Either we had a lot of elastic traction or we had some extra oral traction on these cases also. And we now find that a little bit of this modification in the maxilla can be done with intraoral elastics. Now if we put vigorous elastics on, we're going to get more. So you can notice here that the upper molar lost anchorage quite a bit. Remember the normal pattern of development in the occlusal plane from the maxilla? This came down a little bit, but nothing like we'd expect to find. If we go back and superimpose on position 4, see what happened in the lower arch. There's the profile in the beginning.
これは11歳の時の側房。
And after treatment,
で治療後の側房。
we had a pretty nice looking lip relationship. And if we take our 13-year-old sample, it's pretty close.
だいぶもう15歳の形に随分近くなっています。
This is the normal.
これは正常な13歳です。
So
それを
profile-wise,
載せたわけです。
we put them in at +1 at 130 degrees. Okay. So there's your extraction therapy. Now the next group was a group of patients who were class 1 treated without extraction. First of all, they were age 12 instead of 11 and a half. What are the differences between an extracted case and a non-extracted case? And how do they compare to the normal? So here's the extraction.
こっちが抜歯です。
In the purple.
この紫で示したのが抜歯した場合。
And here's the non-extraction.
こっちが非抜歯です。
And what are the differences?
差はどうでしょう。
Again, it's in the mandible. And it's in the protrusion of the teeth. The cases that needed extraction had a little bit more protrusion. So now we have two factors. The forward position of the upper incisors.
上顎切歯の前方の位置。
Because we needed anchorage to move them back.
なぜならばこの後方に移動させるための固定が必要
And
だ
the
った。
smallness of the mandible.
そして価格が小さいというのが2つ
When the teeth were crowded, but the mandible was good,
目。でも価格よりこ
we'd go ahead and treat it with expansion. So let's go in now and see what happened with expansion.
それでは
These are 40 cases. Now, here they are after treatment.
治療後がこちらです。
We finished the others at 137. These are finished at 127. Okay, the class 1 malocclusions are the most common that we run into. In fact is 60% of all malocclusions are class 1. There's crowding in the denture,
まず歯列に創生があります。
or there's spacing in the denture.
あるいはスペースが空いています。
But the molars are still classified as class 1.
までは
Okay, now imagine this malocclusion. You have them. I've seen them there. End-on molar relation. End-on bicuspids.
臼歯関係、小臼歯関係、大臼歯関係はエンドン、接端交互。
Canines a little high and crowded.
3番は少し上がっています。創生があります。
Anterior teeth a little irregular.
で、前歯部も多少不規則。
Lower arch.
価格は
Usually the lower laterals are lingual. Canine may be out. Lower arch tilted lingually. Usually a mesofacial face. Not a strong mesofacial, but not a real weak one either. If you had a real weak, you'd be class 2 maybe. It comes in typically like you see so many patients. They will have 1 or 2 teeth in the lower arch, 2 or 3 teeth in, and one of the lower laterals will be delayed in coming in because there's no space. If it's moderately crowded, then the midline will shift And this lateral then will come out underneath the canine on the opposite side, and you'll have one lower canine lost early. So you have a midline off in the lower, and you look up in the upper arch.
で、上を見てみると、
The two centrals are in and they're spaced a little bit.
スペースがある。
The canines are there,
3番は生えている。
but there's no room for the upper laterals. Now, how many times do you see that at age 7? If it's a little worse,
もう少しひどくなったらば、
you may have seen that the laterals are coming in the lower, and both the deciduous canines have been pushed out, so you're two deciduous canines short in the lower arch. Now you can have a normal overbite over jet. You can have an anterior crossbite.
前肢部のクロスバイトがある。
You can have a deep bite.
あるいはディープバイトのこともある。
You can have an open bite.
オープンバイトのこともある。
And you can have a crossbite in the molars, a unilateral or a bilateral, all with the same arch length problem. So you have to make a decision now, at this particular time, what to do. Very commonly, do you see this? Now what are you going to do about it? What are they?
何でしょうか。
You can serially extract it,
連続抜歯
or progressively extract.
このプログレッシブに段階的にエキストができます。
That's one choice. All right, let's consider that. If I do that,
それをもししたとします。
what's going to happen to the other teeth?
そうすると
I've invited more drift posteriorly,
で、
and
もっ
I've
とドリフトしま
invited
す。
more collapse anteriorly. So I've made matters definitely toward extraction of all four bicuspids in a case like that. Now what's my next choice?
次のチョイスは何になるでしょ
Leave it alone, do nothing.
う。そのまま
And you know how the general practitioner will look at that. Well, let's just leave it alone.
まあ様子を見ましょう。そのまま。
The child's got a lot of time to grow yet, so let's just give growth a chance here. So we put it under observation, and we watch it, and what happens? The midline shifts over more. The bite gets deeper a little bit. Because once the incisor relationship is set, nature doesn't change it very much. You haven't made it any worse. You haven't damaged it by taking teeth out, but you haven't helped it very much by just sitting by and watching, particularly if it's a crossbite. So is that good? Is that what you want somebody to do for your child? Because as the teeth come in, they're going to be more crooked. At least serial extraction is going to help to align the upper and lower front teeth. Now, let's look at the third option. And this is the one that I do the most. I treat it.
治療します。
I treat it.
治療します。
So how does Ricketts do them?
いやじゃ
What's the first thing I do in cases of this kind?
あ、こういった症例にはまず私がやることというのは何でしょう。
You can rotate the molars. You can move the molars distally. You can widen the arch.
あるいは
Fully loaded, it will split a palate. And before you expand the lower, you want to get the upper out of the way. Because usually it's crowded in the upper arch. So you want to get the upper arch out of the way for the lower to develop.
あの
After you get the side open, you can solder extensions onto it
そこを拡大をすると
to kick the upper laterals out if they don't come out on their own. But I'm amazed when you do it this way how good a class 1 or how good an arch will develop. Now, that's the first thing.
ですから
What about the lower?
何をするでしょう。
Depending upon the type of malocclusion, my number one choice is an opening utility. In the beginning,
で最初は
if the teeth are quite crowded, I will use a ligated utility.
その
Won't even bother banding or bracketing the lower incisor segment. You can put a cervical tie around the lower
サービカル
incisors
タイ
very
を
well,
その看護の
or
一番
a
につけ
tie
る。
right below the contact points. Particularly if you have a deep bite,
特に
ligate them first
でまず
and start the action.
そ
You want to intrude them or hold them down
れで悪化させてその
from
状
going
態に
into
維
the
持
deep
したい
bite.
という場合
And you rotate the lower molar, you tip the molar back,
あるいは大臼歯を少し後ろに傾斜させた
and
り
everybody put their
お
hands
願い
up
しま
here.
す。
And remember all of these
そ
movements.
していただきたいと思い
There's
ます。
4 that you have to remember. First thing is make sure that the tooth is rotated distally
まず遠心回転を
because
し
it's
ているこ
usually
と
rotated mesially.
普通はその
Now I'm going to tip them back.
それから後ろに少し傾斜させます
I'm going to torque them
そ
buckward.
れから強速にトルクをかけます
And I'm going to expand them.
それから
Remember those four movements.
これ4つの動きを今簡単に言いましたよく
Because if
覚
you
え
don't
て
do them all, you're going to get in trouble maybe. Each time you check for those four.
必ず確認
And
し
it
なが
doesn't
らやっ
take
て
any
くだ
longer
さい
than that. Look at that arch, see if it's doing what you want it to do. This is the most common treatment that I do. Okay. Now you can go ahead and bracket them. And if you've got an asymmetry,
非対左右非対称がある
this is an opening utility.
場合ですでオープニングユーティリティを使います
It has two helix in it.
ひり
An opening utility. If it is severely crowded, yes. If it's just ordinarily crowded, just a plain utility in here, it's mostly intraoral adjustment. Once you get the quad helix in,
で上顎にクアドヒリクスが入っていて
intraoral adjustment.
これもその
So you don't take these out just for the fun of it. I mean, you've got a busy practice.
忙しい
So you explain what you're doing.
ですからこういうことやってるということも説明してあげればよろしいで何をやってるか見せてあげればよろしい
And you'll never get the question, is that all there is to it?
ですからそれほど時間かかりません口の中でちょっと調節するだけですよということについては
So if it's minor, it's a plain utility, which we just straighten out. The next one then would be a little more crowding, in which I use a Z utility. Understand?
こういうの
Now I've got more room
そうすると広がって
to
きます
expand. Make it in a Z shape.
Z 型に作ってやると広がります
Now you've got the arms to bring upright and then extend further. So you can get quite a bit of distance out of a Z utility. The last is to use a Z helix. Now you've got a lighter, more springy action. So that's my first choice. I also, lots of times, will use a cricket in the lower. A cricket is a removable clasp Crozat-like appliance with a helix loop on it, particularly if the first molars aren't in yet. I can clasp very nicely around the second deciduous molars because they are round and will lock a clasp very well. So the cricket is a nice choice.
でこれを使うのもいいと思います
And I'm amazed at how well the children like them. Here, let me put it in.
だから自分でやるって言うんです
They want to show you that they can do it. They're proud of it. It's an achievement for them. So let them do it. Now, I also will sometimes use a Willson lingual, particularly if I want to go laterally. And I have a patient that I can't trust. My first choice would be a cricket.
クリケットを使いたかったんですけれども
Now, particularly if I want lateral expansion and don't want to move the lower incisors forward. So these are the options now that I see in the lower arch. Now there's one more option, and that is the case that has a lot of crowding and has good potential, in which I deliberately want to move the molars backward, and I don't have a deep bite, and that's the bumper.
でこの場合にはバンパーを使ってよろしい
Lay the bumper down in the sulcus of the lower arch and advance it 2 millimeters from the lower incisors. Leave it in 3 or 4 months and it'll be back against the incisors. So those are the 4 options, or 5 options,
5つですか
that are in the
使える
lower
ものを言いま
arch.
したか
And if the case has any high convexity at all, you may want to use a headgear,
その場合はそのヘッ
even
ド
in the class 1. It's absolutely amazing what a headgear will do for the development of an upper arch, because it will widen the palate too. It will move the upper molars distally. It will have a shielding effect, and the upper premolars will move laterally, and there's a lot that you can do there. Now the third option in the upper is the utility up there, an advancing utility there. You can also ligate those, but they're harder. So we'll usually bracket those teeth and use an advancing utility up there. If the midline is off, make it advancing utility or a Z shape on one side, normal on the other. After you've got space,
でスペースが取れてきましたらば
sometimes you find that there's a tilt. So make, in those instances, sometimes put in a 1622 utility. All the other time use 16 square utility. I prefer the blue Elgiloy wire far over any other wire that I use. One thing I like about the blue utility is it permits me to do a lot of intraoral adjusting, and its properties are the closest to a gold wire of anything I have
それ
found.
からブルー
If you want to see proof for that, look in Thoreau's book on the edgewise appliance. Raymond Thoreau, where he compares stainless steel, gold, and chrome cobalt wire. The Elgiloy wire has chromium and cobalt in it. It's soft and kind to the tissue, and it permits you to do a lot of adjusting inside the mouth.